Nothing can be deemed as history of the past. So now we bring to you a panel discussion on tropical diseases and MISC in the PICU. For this panel discussion, I invite the esteemed moderator, Dr. Arun Bansal. He is the professor of the Pediatric Emergency and Intensive Care Unit of the PGI MER Chandigarh. As a researcher, he's been part of multicentric national and international projects, and he's been the main guide to more than 30 DM and MD students. He's got more than 100 international and national publications to his credit, and he's authored more than 50 chapters in many pediatric books. He's the associate editor of 2 renowned books in pediatrics, and he's been the EB member of IAP from 2021 to 2020 to 21 and 21 to 22. He's been the general secretary of the intensive care chapter of IAP from the year 2020 to 2022. Welcome, sir. I also invite the renowned panelist for this session, Dr. Mahesh A. Mohite. He's the pediatric and neonatal intensivist at Sai Childcare Clinic, New Panvel, Maharashtra, and BJ Wadia Children's Hospital, Mumbai. He's the President-elect 2022 of the IAP Intensive Care Chapter, and he's a teacher and council member of the Pediatric Critical Care India. Next, we have our panelist, Dr. Hari Krishnan. He's the consultant of the Pediatric Intensive Care Unit, Birmingham Children's Hospital, UK, and the research committee member of WF PICS and the deputy chair of UK PICANet Clinical Advisory Group. He's the social media ambassador of PCCM Journal, founder of PICUJournalWatch.com, co-founder of PICHub app. His areas of interest include neurocritical care, data, and informatics. He has more than 30 important national and international publications to his credit. His publications have featured in important journals like The Lancet, PCCM, CCM, Challenging Concepts in Pediatric Critical Care, Oxford University Press, etc. The third panelist for this session would be our own Dr. G.V. Basavaraja, Honorary Secretary General of Central IAP, is the Professor of Pediatrics and in-charge of PICU of the Indira Gandhi Institute of Child Intensive Care, Founder Secretary of the IAP ID Chapter of Karnataka in the year 2011, Chairperson of the IAP Intensive Care Chapter 2020. He is the convener of Scientific Committee, PEDICON 2017 and 2018. He has more than 60 publications in index national and international journals. He was conferred FIAP in the year 2017 and the BC Roy Award by the IMA Karnataka in 2020. Over to the moderator and the panelist for an enriching session. Thank you, sir.
Thank you, Madam, and thank you, Dr. Thangavelu, sir, IJPP, and DIAP for organizing such a wonderful CME. Good morning, all. And I welcome all the panelists, and I'm seeing Mahesh with a new makeover. So that's a welcome change. I muted. Mahesh, you are muted.
No, I said it's a changeover from BC to AC, before Corona to after Corona.
Good. We need to see AC no more. We need to come out of that. Welcome. So this is a very interesting topic of Srinivasan, sir. Good morning, sir.
Good morning, Srinivasan, sir.
Good morning, sir.
So this is a very interesting topic of tropical infection and MISC. So what we will be doing today is we'll discuss two cases, a classical case of MISC and another one of a tropical infection masquerading as a MISC. So as we proceed and we discuss the case among ourselves with our panelists, we'll take on few important questions which are query to almost all of our pediatricians when we are managing any of these diseases. Okay. So let's start straight away. We'll start rolling. So this is a case who is a child who is a 12-year-old male child who's a resident of Chandigarh. He had presented with, these are all real cases which he had seen in last 15 days or months. So fever of 5 days, redness of eyes, vomiting and abdominal pain since 2 days, had loose stools and fast breathing since 1 day. So what we see was fever was high grade up to 104 and not relieving completely with medication. The eyes were red and there was no discharge. He had vomiting, which was non-projectile, 2 to 3 episodes per day, with mild abdominal pain on the epigastric and right hypochondrium. Also had loose stools, 2 episodes, semi-solid to watery, and fast breathing. There is no history of decreased appetite, urine output, no history of jaundice or any bleeding, no history of any neurological manifestations. The family history of COVID was there in the grandfather 1 month back, but no other positive family history. Other history was insignificant. Obviously, COVID becomes important in these days. Any child comes, we always take a history of COVID. We all do. On triage, when we examine the child, his airway was open and stable. His respiratory rate was 38, so he was slightly tachypneic with increased efforts. Heart rate was 150, so tachycardia was there. BP was 102/40 at 12 years. Peripheral pulses were feeble. Skin temperature was cold. He was neurologically normal. Blood sugars were normal. But he had a fever of 100.8. Non-purulent conjunctival congestion was present with dry cracked lips and tongue. There was erythematous blanchable rash over back of the trunk. So he was classified as respiratory distress with compensated shock and level 1 urgent as a triage category. There was no anemia, pallor, clubbing, lymphadenopathy, no signs of dehydration. Congestion, like I said, cracked dry lips are there, rash was present. Heart was normal. There were occasional basal cracks in the chest. Liver was palpable 2 centimeter, but spleen was not there and no free fluid, and neurologically was normal. So this was the rash which was there in this child. So on database, we have a 12-year-old child with high-grade persistent fever for 4 days with redness of eyes, vomiting, loose stools, family history of COVID, and on examination at conjunctivitis, rash, oral mucosal changes, tachypnea, tachycardia, feeble pulses, and hepatomegaly. So we classified him as a broad classification of acute febrile illness with respiratory distress with compensated shock. So what would be the differential diagnosis in this case, Dr. Basavaraji?
Yeah. Whenever we come across a patient with a 12-year-old with an high-grade fever, with involvement of a mucous membrane, cutaneous involvement, with an other systemic manifestation like GI involvement, tachycardia and tachypnea, that means there is a multi-system involvement. And one of the things with the past history of a COVID-19, with the present pandemic, we always, the first thing which comes in the mind is a multi-system inflammatory syndrome. But before thinking about a multi-system inflammatory syndrome, one of the things as a clinician, what we need to look at it in the clinical practice is we need to think about other tropical infections. What are the other tropical infections which can come present like this? One of the common thing which comes in our mind is a dengue fever. So what are the things which favors a dengue, what is not? When you look at a dengue infection, majority of the time, there will not be other manifestation except fever and pain abdomen. That's the usual manifestation. Fever will be there on 3rd and 4th day. The patient develops a pain abdomen, subsequently will go into the shock. And tachycardia is not a manifestation. Here the heart rate is 150 with a tachypnea already setting in. So that is the other thing we need to consider. Apart from dengue, what are the other things we need to consider? Leptospira. Leptospira is one of the clinical condition. We need to keep it in mind whenever the child comes to us with a toxicity, with an high-grade fever, with a conjunctival involvement. Conjunctival congestion is also a typical feature of leptospirosis. We need to keep that into the mind. But one of the things in a leptospirosis, icterus will be there. Icterus is a thing apart from hepatosplenomegaly and other things. Scrub types, it all depends upon the endemicity in which you are working. For example, if I am working in Hyderabad, Karnataka, or in this part, even nowadays it is occurred all the parts of India. The scrub or rickettsial fever is another thing we need to keep it in mind. Rickettsial fever. Then if you leave apart rickettsial fever, dengue, and leptospira, other thing, enteric fever is one thing we need to. But in enteric fever, conjunctival congestion is not that common. Mucocutaneous involvement is not that common. Rashes can be there on 7th day, but the conjunctival congestion is not a typical feature of any enteric fever. I'll consider enteric fever is also one of the possible thing into the mind. So these are some of the initial thought when the patient comes to the emergency department, apart from MISC.
Yeah, so very well summarized, Dr. Basavaraj. So we all will agree that though MISC is now the first thing which we will consider in this pandemic, but then we should not forget our own old traditional tropical diseases, which can mimic or which can present with the similar kind of features, with some here and there symptoms being slightly plus and minus in each of these. So the stress because in this is that when you are making a differential diagnosis and approaching a case, don't get blinded with just one diagnosis. We have to keep our mind open and move forward, and we will see how we move in this case and then in the subsequent cases. So this is the WHO definition of MISC, in which we have criteria of any child from 0 to 19-year-old with fever of more than or equal to 3 days, and any two of these following, like rash or purulent conjunctivitis or mucocutaneous inflammation, hypotension or shock, features of myocardial dysfunction or coronary abnormalities, evidence of coagulopathy, acute GI symptom, and elevated ESR, CRP or procal, and with no other obvious cause of inflammation, and evidence of COVID in the past, contact or the child himself being positive. So if we go from this history and examination, so if it's into definition, we have two of these following criteria and contact is there. So we will see subsequently in these two whether this child fits into it, this or not. We also have with us now an esteemed panelist, Dr. Hari Krishnan from UK, Birmingham, who has seen a lot of MISC in his practice. And that's from where the first case of MISC from UK was reported last year in April. And they had labeled it as PIMS. So Dr. Hari Krishnan, welcome, please. Good morning. It's quite early there in the morning.
Thank you. It's a great opportunity. Thank you for the invitation.
Yeah. So can you comment on these different definitions which have come up? Like, you started with PIMS, then WHO came with their own, CDC came with their own definition. So why we are having multiple definitions, or is it with almost the same, and which one to follow?
You're quite right. I think there are not just the three that you have alluded to. There are actually Canadian Pediatric Surveillance Program came up with their own definition, and British Pediatric Surveillance Unit came up with a bit more precise sort of definition of numbers and so on. So there's actually 5 different definitions floating in the air. While I agree that that is causing some confusion, most clinicians, most intensivists are aware of what they're talking about, regardless of whichever definition you follow. There's quite a lot of similarities between each other. There's subtle differences. I don't think that should let us distract from one another. I think it'll be great if the organizations come together and adopt a uniform nomenclature and a uniform definition. Undoubtedly, that will be good for research community and benchmarking outcomes, and as well as comparing various treatment regimes with one another. But at the bottom line, for an individual child, I do not think whichever definition you follow is going to make that much of a difference. Barney, my colleague, and I wrote a paper in JPIDS comparing all of those 5 different definitions. But yeah, I don't think it's a big issue.
While we are on this, Dr. Hari, like you had already compared and published different definition and the variation. These definitions, majority of these came somewhere in last year, May, June, when the cases had just started. Now we are seeing a lot of variety of MISC also. There is a lot of phenotypes. And many of our colleagues here in India feel that this is too broad a definition and it's not very specific to various phenotypes. Do you think it's a time to revise, come together and revise this definition and come up with something new?
I don't think something new necessarily, but yes, I think some acknowledgement of presence of maybe a more Kawasaki type phenotype and more toxic shock phenotype, and separating out the respiratory COVID phenotype out of this condition. That may be helpful. It may provide some clarity, but I the KD phenotype and the toxic shock phenotype may ultimately need the same treatment with some subtle differences. You may want to choose one rather than the other, but we're not really sure as to whether the differences in management are warranted. They happen, but we're not sure if that is truly what is required for the child. And therefore, I think there is some uncertainty as to whether you need to do it or not. But I agree, some acknowledgement of different phenotypes, particularly the KD phenotype and TSS, may be helpful.
Maybe helpful. Great. That's a great thought. So these discussions which we are having, most of the panelists don't know about the case and they also are not aware about the questions which are coming up. So even if any panelists want to ask any questions to each other or any doubts are there, I welcome them to raise a hand so they can come forward so that we can all share experience with each other or what is important for everybody. So this is a MISC management which the IAP came up with these guidelines in April 2021 and they were widely circulated. And this is the flow chart in which how you have to proceed and what all investigations you have to do. We are also in the process of revising this April version and hopefully by next week we'll have the version 2 coming up with slight changes like Dr. Hari said, recognizing the KD phenotype and the toxic shock and separating them in the management. So that will be highlighted in the next version. So if you see, you flow that if you have a clinical suspicion of MISC and child has now signs and symptoms of MISC, you proceed whether the child is having shock or no shock. And if there is no shock, you go to the tier 1 investigation, which include the complete blood count, LFT, RFT, ESR, SARS serology, and also along with workup for other co-infections, like Dr. Basavaraji said at the start. And if tier 1 is positive, you go to the tier 2 investigation and work up for those. But if shock is there in the child, then you do all these investigations simultaneously. So Dr. Mahesh, you have any comments on this, that how do you proceed in these investigations for any child of suspected MISC? Is it okay, or you think there is something more need to be done, or it is too difficult to do at a tertiary or a periphery level? Sorry.
I feel present protocols are all inclusive, and every defined case of MISC, if you follow this, then he lands up with a huge number of investigations, which if I look at my learning curve last 9 months, I believe 80 to almost 70 to 80% patients perhaps did not require all these investigations. Maybe first time okay, but follow-up perhaps one need to be very choosy, looking at the availability and cost constraint of all these investigations. So once I defined primarily, like if you look at the definition inclusion criteria, they are fever followed by 2 or more than 2 systems involvement, and then inflammatory parameters, which essentially are ESR, CRP, maybe occasional procal. Then the ruling out of sepsis or infection, which again lot depends upon the clinical ruling out and to some extent on the lab ruling out, and finally whether there is any evidence of COVID. If you take the inclusion criteria from 4 these, I seriously believe that all those investigations upfront may not be required. And the Indian's perspective, as you said, in a rural or semi-rural area, if I do all these investigations, those investigations themselves will cost more than 5 to 10,000, which I can definitely I can reduce it, because I would say almost 60 to 70% of this category were those mild inflammatory category, which don't require all these investigations. Maybe 10 or 20 or 30 will be in the KD or the toxic shock, which all these investigations are justified. but we can do a lot. Like for example, you said D dimers, fine, once I may do it, but the rest all detail LFTs, KFTs, pro BNP, fibrinogen, or I mean, I'm just trying to learn from experiences. Yes, first 5-10 cases I did everything, but we have seen almost about 60 in my own setup, the MISC. You know, what have you seen? More than 200. And then we're looking, maybe it's worthwhile looking at our data and find out whether we could, when we define guidelines for the nationwide reading, we need to be giving it something not all inclusive, maybe from the learning curve, whether we can cut short for a particular group, go up to this, and you find this positive, then move up to the next investigation, rather than giving it as a block that everything is to be required, because that over the time could be costly and we'll be giving a wrong message as well. That's my take.
I think that's a fair point raised by Dr. Mahesh, that majority of MISI are also fall in that mild MISI, or what the terminology people are using as febrile inflammatory state, in which they either improve on their own, or they don't worsen, or they don't require so much of the extensive investigations. So maybe tier 1 investigations, simple ones are okay for them, and we can just stay there and don't do anything and follow them. And in case they worsen, or then they can be referred to a higher center, obviously. Then they can't be managed also at a periphery level. So we need to have some insight about our own resources and then manage accordingly. Dr. Hari, in these investigations, any specific investigation which might differentiate between that, these like if pro BNP is high, it is more of a cardiac phenotype, or some other marker is high, it is more of a KD phenotype, anything which can guide us in the initially in the management, or putting it in that limb of the management?
Yes, I think in our setting where we don't worry about cost as much because it is government funded healthcare for everybody. We still try and keep costs under control, and we try and minimize the number of investigations that we do. But nevertheless, we find it helpful to track at least one cardiac biomarker, and we would either choose either BNP or troponin T to track to see whether they get better with improvement in other inflammation. We then use D-dimer for tracking vascular inflammation. We then track pretty much mostly only CRP. We don't do procalcitonin or IL-6 because they pretty much go hand in hand, and any one of them will probably do. We track one of them for general inflammation. Ferritin, we find it quite helpful as well. All the more so because in case the patient ends up receiving tocilizumab, then you can't use IL-6 or CRP because that's sort of cut down, and therefore you would need to use an alternative marker of general inflammation to see whether that's come down. And in that case, we would use a ferritin. We generally haven't found doing fibrinogen or LDH or triglyceride that helpful for MISC PIMS-TS in particular. That said, I acknowledge that that would be important in differential diagnosis of whether you are dealing with HLH rather than MISC, or there is also a phenotype of MISC which may be more overlapping with hemophagocytic lymphohistiocytosis. So that sort of stuff may be helpful. But on the whole, I think I agree, doing only one marker for a cardiac biomarker, one marker for a vascular, and one marker for general inflammation may be sufficient. And we try to do them every day if they are admitted to intensive care. But if they're not admitted to intensive care, then maybe once every few days would be enough to see the trend. And if there is a sustained fall, then that probably is enough. You don't necessarily need to track it till normalcy.
Yeah, I think that's a great comment, that you just don't overdo it, but maybe from each category you can do one marker and then follow it up serially. So rationalizing and with some scientific background of these investigation is important, and we should not do blindly all the package or the cocktail of investigation. So like Dr. Hari said, even in UK where they don't worry much about cause, they also rationalize and triage or whatever, they prioritize their investigations accordingly. So it's all the more important for us. So then as we move forward to the management, so MISC has been classified either presenting with shock or life-threatening, or no shock or life-threatening. We are in the process of adding a third limb here, which would be the KD phenotype, which will be out next. But before that, let us discuss about how do we manage a child who presents with shock or a life-threatening disease. We give IVIG 2 gram along with methylprednisolone at 10 to 30 mg. We give empirical antibiotic and aspirin to all if they present in this. And we add anticoagulation if they are having coronary aneurysms and they are having Z-score more than 10. And in no shock, we give a low dose methylprednisolone at low dose along with IVIG. So these are the recommendations. So Dr. Basavaraji, what are your comments on this? That people are commenting that this is will lead to overuse of IVIG and steroids. How can we rationalize it? And then we will seek Dr. Hari's comment also on this subsequently, that what do they practice?
So presently the debate which is going on whether to use an IV immunoglobulin to all the patient, which is MISC, fitting into the MISC, with shock, without shock, both the things. Or should we go with an IV immunoglobulin, without IV immunoglobulin like steroid? See, this is one thing where the judicial use of any things really matters to us. So when you go back to this history of use of an IV immunoglobulin, it was basically things started with all the Kawasaki disease like presentation. That is how the things started using an IV immunoglobulin, and methylprednisolone is into the things. So coming back to the way the disease which is changing a lot, and the way the IV immunoglobulin is a thing which is costliest, and we need to look at it an alternative things for an IV immunoglobulin where misuse of things can occur, and where we need to use definitely the immunoglobulin, where we can avoid it. My thoughts at this stage is my own experience. What I'm talking is, we have almost in the second wave, we had almost 38 patients up in a MISC so far in the last 10 days. What I use in a patients within a KD phenotype, I'll go upfront with an immunoglobulin and steroid. Whereas without any KD phenotype, where I'll go with a methylprednisolone. That's how around when you looked into the outcome really it doesn't change in terms of a mortality is concerned. But as far as the hospital stay is concerned, yes, there is a significant reduction if you use an IV immunoglobulin along with the methylprednisolone, where the reduction in the ICU stay, clinical recovery is much faster with the use of an immunoglobulin and methylprednisolone instead of using a methylprednisolone alone. And total hospital stay is significantly, it will be reduced in a case of an immunoglobulin and steroid. If you look into overall things, ultimately the discussion what I'm doing is, it will go in the way of remdesivir, how we started the remdesivir in left and right in all. Similar way, IV immunoglobulin and steroid will land up like that. Ultimately, things need to be revised as the days advances. This is what at the initial thought at this stage.
Yeah, I think that's well put. And Dr. Mahesh, yes.
I just wanted to make one comment. I feel these guidelines of IVIG, we came up with the initial document who came from UK and subsequently from WHO. And they are set about a year ago when this disease was totally new to us. And all the protocols, though this disease is in the later age group after 5 to 10 years, unlike the KD, which is less than 2, 3, 5 years, all the protocols were based on the rheumatologist apprehension of this disease similar to KD. But by this time, we have realized the KD protocol, the KD phenotype, classical KD phenotype, less than 6 months baby when they get KD, 40% of them have a coronary damage and persistence of it. Children up to 2, 3 years, about 25% have a coronary persistence. And last week, I took a review, a survey, verbal review of 4 leading pediatric cardiologists in Mumbai who are following 500 MIC over last almost 9 to 12 months. And I asked them serial questions. And to my dismay, now one of the criteria in the middle column, you said Z-score more than 10. They have, of the 500 cases, suppose they have seen over last about 10 months, about 25 to 30% had myocardial dysfunction and coronary affection. 70% did not have anything. And of those coronary, they have not seen a single one more than Z-score 10. So all of them, whoever had a coronary affection was between 2.5 to 10, the moderate category. That's one. And they said almost 60 to 70% of these MISC coronary, all those things were followed for more than 3 months. Not a single one is left with any coronary or myocardial dysfunction at the end of 3 months. This is something which is unpublished data, but this is something which I have taken as a survey. Now we clearly understand that this disease is not the KD that we are seeing in the infantile age group. Now extrapolating those protocols of KD pre-corona to the present MISC was okay about 9 months ago when the disease was new to us. Now sitting after 1 year, knowing those whatever 500 cases in Mumbai and all over India, it may be 5,000. At the end of it, it's a time that we have to make our data and confirm that this disease is not KD. So if it is not KD, then we need to decide really we need to have that IVIG draining into the gutters. I'm right, sorry to say that rash word, but it's a time that we have to look at the data, what we have, and we have to be more stringent about using the IVIG. Otherwise, we'll be really overusing our resources. That's a matter.
I think that's a very, very important point. We need to have our own data to answer all these questions, and maybe everybody had experience, have their own experience of managing shock or KD type or the mild MIS or the HLH versions of this MISC. Dr. Hari, what is your protocol of giving in shock type? Do you give both IVIG and methylpred together? And if methylprednisolone you are giving, what's the dose which you usually give in these cases?
Arun, before I answer that, may I just share some personal thoughts about the treatment of MISC as well? I agree with what the other panelists are saying. I think that we need to acknowledge that we do not know how to treat this condition appropriately. We know that whatever treatment you do, children are getting better. Children get better, 2 to 4 days, sometimes 3 to 5 days. Sometimes up to 2 weeks if they're really sick, but they get better regardless. And when you look at 3-month outcome, 6-month outcome, they're uniformly favorable. The longer term outcomes are now being published, and GOS published their data about 2 weeks ago. I think they had one child with coronary aneurysm that was Z-score of 9 rather than 10. As Mahesh said, most of the coronary aneurysm that was seen in the UK were also between 2.5 and 10 Z-scores. We did, as you might know, we did a multi-center UK intensive care study, which was a third published study on MISC. We did a follow-up paper, which is sort of, going through various journals at the moment. 6 of about 75 children that we studied in intensive care actually have coronary dilatation between Z-score of 2.5 to 10. All of those 6 had intense inflammation. All of those 6 had at least IVIG, if not IVIG and steroids. We're not necessarily certain that they actually prevent coronary aneurysm from developing. It may also be the case that coronary damage was already existing even before you tried to reverse it with IVIG or steroids, and maybe they were unsuccessful. But I think it's time to acknowledge that we do not know exactly what is required. We do know exactly what is done in many places, and they are different. There are various recommendations, there are various guidelines. That is evidence-based medicine, that is not evidence-based medicine. The way to put them into a trial, and we tried to do that in the UK. So if there is a child that is admitted today in my intensive care, I would counsel family to recruit them into recovery trial. Although recovery trial was originally started off only for acute COVID, it then branched out to include, because it was an adaptive platform, you could include new treatment modalities and new definitions for sub-arms, and therefore MISC PIMS-TS was added as a sub-arm and recovery trial, and we would try and randomize them between standard of care versus IVIG versus steroids. Now, there are some of us who would be willing to stick to the randomized arm, and if a child is randomized to nothing, i.e. no IVIG or steroids, some of us would be happy to stick to that. Whereas some of my own colleagues would not be happy to stick to that. And they would say, if the child continues to have fever or inflammatory markers deteriorate and the child is randomized to standard care, they would provide out of protocol treatment, and they would either choose IVIG or steroids. As you would know from many published papers, yes, IVIG still is the first line therapy, and then steroids are probably competing. But I would say that we do not know exactly what works. On that regard, there are two important publications that will come out. Recovery trial will close the MISC arm, and they will analyze. We've recruited about 300 children in the UK into the recovery trial, and therefore that analysis will come out. I think that most of the patients who were recruited into the standard care arm essentially had out of protocol treatment, and therefore I'm not certain we will get an answer for do we need any treatment at all. I do not think we will get that answer because pretty much everybody had some treatment. And the other paper that is accepted that will come out very soon is BAT's study, Best Available Treatment Study, that was started by Professor Mike Levine in St. Mary's in London. They analyzed sort of, I think 600 patients worldwide, reported anonymized in just as a survey type setup. And they've analyzed their data, and that's been accepted in NEJM. That should be coming out any day. Actually, I looked up to see if NEJM published it this morning. It hadn't. So it will come out maybe in the next few weeks. And that might shed some light on whether steroids work better or IVIG work better. But important to say, we will unlikely to get an answer on whether any treatment is necessary because there is no confidence in people to not treat a child when they're deteriorating.
Yeah, I think we need some good hard evidence in a form to finally come out with something which is very practical and pragmatic. Similarly, on the same line, we also have a question in the chat box by Dr. Puvai that a child with shock on 2 inotropes given IVIG, and guidelines say, most of the guidelines say give methylprednisolone 2 mg per kg, but what are the indications of starting high dose methylprednisolone, that is 10 to 30? Though IAP guidelines recommend high dose in this stage for the same reason, that a child who comes with shock should be started on high dose methylpred along with IVIG in these cases. But the ACR, the American College of Rheumatology, recommend low dose there, and then they say if they are refractory, you move to the high dose. So by any of the panelists, any comments on this, that the dose of methylpred? Yeah, Basuraj.
Yeah, what I practice in my intensive care unit is I'll go with any patient with a shock. I'll preferably go with an high dose steroid of 30 mg per kg. In fact, pulsing up for 3 days, then followed by 1 to 2 milligram of an oral prednisolone for 3 to 4 weeks. Suppose if the patient is not in a shock, it is just this one. That's the time where I'll go with a low dose, that is a 1 to 2 mg per kg. That's the way I practice.
So all the other panelists agree on this, at least on the methylprednisolone dose in shock? So I think that
Hypotensive shock, that, yes, definitely boluses. Hypotensive shock, we give 30 mkdo, 1 day, maybe at times extended to 3rd day, and then we get on to tapering. One interesting thing, just a quick comment.
Yes.
In the periphery, those patients where you feel IVIG is required, even with the present concept, few patients don't afford, and a pediatrician is forced to give only steroids. So those kind of patients are also followed over last 3 to 6 months. And at the end of it, the outcome has been unanimously successful. So it's really, again, a point. In India, gives you opportunity to learn faster than UK, or like Dr. Hari Krishnan said, everything is available, or maybe at PGI, at you or on the corporate center where everything is available. In the periphery, your treatment is guided by the availability of resources. So we have 100 patients who require IVIG, but 50 cannot afford and 50 can. So they are followed subsequently. At the end of it, you realize that both have done equally well. So this is much more of case control study, which you have hand on. And that's what we have seen over the last 6 to 9 months. Our outcome, whether they received IVIG or not, has been almost equal. So that's a good learning curve. That's what I have been talking about. But yes, hypotensive child, 30 mg we have hit definitely to start.
Actually, these guidelines of combination therapy of IVIG and methylprednisolone came from the first paper of the French group who published in JAMA Pediatrics, in which they had compared IVIG and methylprednisolone versus IVIG alone. And they found that IVIG alone does not work. They have a higher mortality and higher hospital stay. But we don't know whether methylprednisolone alone works or not. That answer probably we'll get from the recovery trial, or if we go get some of our own data from this. Yeah. So moving forward, this was the investigations in this child on day 1. Had significant lymphopenia. Lymphocyte count of only 4 of day 1, 2, and 3. Slightly raised AST, ALT, urea creat were normal, platelets were okay, bilirubin and other LFT liver function tests were normal. So we very classically see significant lymphopenia in these cases of MISC. So is it the same experience? An open question to all panelists.
Yeah, this is a common thing. What we get it in whether it is an acute COVID, whether it is a MISC, the similar things where the lymphopenia is a predominant thing.
Yes. And the other inflammatory markers like CRP was very high, which subsequently came down. ProCal was high, which also came down. IL-6 was very high, 987. Pro-BNP was also high. You had a high ferritin. TROP-T was okay, CKMB was okay, but D-dimer was also high. The COVID antibodies were positive in this case. And the other workup for sepsis was negative, blood cultures and all were negative. So there is a question by Dr. Ramchandran in the chat box, Dr. Mahesh, that do we need to rule out infections before starting the treatment? Because then it will take time. So or we start the therapy and send the workup side by side.
We do send a workup side by side, and when we are doubtful about the infection, we start steroid under the cover of antibiotic. That's a practical tip. We do give antibiotic these patients. So I get a hypertensive shock where I have a doubt whether this is a septic shock, then I will be sending the cultures. I'll be sending all parameters. And if I feel this is MISC related, then in the shock patient, as we discussed in the previous slide, we are giving steroid upfront and we are adding IVIG later on when it is indicated. So that toxic shock syndrome like scenario, my first take is steroids, and most of the institutions follow that protocol and will give IVIG in subsequent 24 hours. And this patient is given under broad spectrum antibiotic coverage. When I'm in doubt, yes, I do cover under antibiotic.
Yeah, I think we send a workup. We should not delay the treatment of MISC in this. And then you can always await those investigation and change accordingly. So echocardiography was done at admission. So his ejection fraction was just 35 to 45 with the moderate left ventricular dysfunction. His coronaries were all normal, so within the range. This ejection fraction improved with treatment over 3 days. The coronaries remained normal. So what are the other differential diagnoses? I think I'll ask Dr. Baswaraj because Dr. Hari is not seeing this kind of infections in his setup. So Dr. Baswaraj, like I think you already pointed out all these, maybe we should not go into all that. But if you want to have any last word on this, that all these mimickers can be there.
Yeah, all the mimicker can be there. That's the thing. And apart from that, we need to look at it in a chikungunya is also one of the other things where we are getting the thing. It may not be present like in a shock, but it is known to affect the multi-system. We need to be aware about that too.
Yeah, I think yes. So subtle differences are there, which you can find out. Like if it was dengue shock, we don't have thrombocytopenia, no evidence of capillary leak. Enteric fever, these are not definitive, but these are very subtle things, and they may or may not be there. Similarly for scrub, similarly for toxic shock. So you have to make a very rational judgment at that time. So this child, respiratory distress, there was cardiogenic pulmonary edema, required, initially started on nasal prong, but went up to onto NIV of BiPAP and then gradually tapered and onto room air by day 4. Compensated shock was managed based on the initial echo reports which we had. So he was started on inotropes, noradrenaline, and also needed milrinone. And then by day 3, all these inotropes were tapered and stopped. For MISC, we gave IVIG and methylprednisolone at a higher dose, 10 mg per kg, and aspirin was also started. For suspected sepsis, we gave ceftriaxone and doxycycline because in our part of the institute, we see a lot of scrub also presenting with similar presentation. So they was also stopped once we got all the reports, and MISC were more stop possibility. So by day 3, we stopped all the antibiotics. So I think that answers Ramachandran's query also. And workup was negative, so that was all stopped. The patient became afebrile. And then by the end of day 4, we had discharged the child on day 5 on oral prednisolone and aspirin. So this was the flow of the patient which we had done. Any comments on this before we, by any of the panelists before we move to the second case? We are already left just with 20 minutes.
Yeah, as far as the antibiotic choice is concerned, absolutely ceftriaxone, doxycycline is quite okay. If you're thinking about in a toxic shock syndrome like a phenotype of a presentation, one of the emphasis should be given to the covering in a streptococcal infection. Clindamycin, other things can be considered. That is where if you have not ruled out any toxic shock syndrome.
Okay, Dr. Hari, you have
Comment
any comments or anything on this before we move forward? Anything you want to make or ask
our
about
practice would
MISC?
be similar. Broad spectrum antibiotic cover, don't delay antibiotics first. If you are treating MISC and you're uncertain, you could wait up to 24 hours, but not necessarily longer, is what is currently followed.
Okay, Mahesh?
Just one point is related to anticoagulation. When you have a myocardial dysfunction defined 30 to 40% with your D-dimers also high, whether transient you are going to use low molecular weight heparin rather than aspirin in such kind of a patient. So again, that will be something which has to be, your data has to derive over the time. Because again, the action protocol mentions some guidelines where myocardial dysfunction, coronary dilatation, D-dimers more than 5 times, you have to do anticoagulation, low molecular weight heparin for 2 weeks, and then aspirin. So a lot of things need to be defined. This is another raw area which requires to be a relook over next maybe 6 months, 1 year to decide what to do.
That's a good question, Mahesh, which you raised, because it's a very important query by many of the practitioners. I'd just like to highlight that last week a paper came up by the recommendations by the pediatric cardiologists of US and published in Pediatric Cardiology. You can refer to that.
Protocol.
Yes. So in which their anticoagulation guidelines they have given, and they have said that if your coronaries are between 2.5 to 10, then you can, and the D dimer and the left ventricular ejection fraction, mild to moderate dysfunction is there, you can start at a low dose anticoagulation. And if it is more than 10 or moderate to severe dysfunction is there, then you can go to a higher dose or a BD dose of enoxaparin can be there. So those are again, like Hari said, eminence-based guidelines or little evidence which we have, but obviously we need more information on that. So moving forward, we have a less time, so we need to finish the second important case. So this is a small child, 5-year-old girl, again coming from Punjab, had abdominal pain for 2 days, for a few days back, developed loose stools and fever subsequently. So abdominal pain was mild periumbilical, which decreased with medication. Fever was intermittent, and but high grade up to 103 degree with chills. There were loose stools, 3 to 4, no blood or no mucus, and there was skin rash over the cheeks and the limbs. And there was a history of decreased appetite, but no respiratory signs, no urine output decrease, jaundice, no bleeding, no headache or neurological signs. So this is again a very similar presentation to what we see in MISC. Those signs and symptoms can be very similar. So child was admitted outside and was suspected as MISC because the symptoms and the presentation was almost similar. So there she received IV fluid, IV antibiotics. They gave dexamethasone and enoxaparin and was referred to PGI. Like again, almost similar treatment for MISC. And there is no history of past contact with COVID in this child. On our triage assessment, Pentagon, we have a stable airway. The breathing pattern and respiratory examination was normal. Cardiac-wise, her blood pressure, circulation, CFT, and all were normal. Neurologically was also okay. Blood sugar was 96. In this case also, there were dry cracked lips and tongue was present, but no fever, no skin rash. So we categorize as non-urgent and a stable child. And on examination, like I said, maculopapular rash was also observed over trunk with dry cracked lips. No other general physical examination. Her systemic examination was almost normal, just liver was palpable 3 centimeters below right costal margin. So almost similar presentation as the previous case. So on database, we have a 5-year-old with abdominal pain, initially with high-grade fever, loose stools, and skin rash. On examination, the child was stable with some oral mucosal changes with rash and mild hepatomegaly. So again, acute febrile illness with variety of differential diagnosis. So again, Mahesh, what will you consider in this case? And can we consider MISC as a first possibility in this?
Just slight clarification. Fever of how many days, Arun?
Fever for 2 days, 5 days back.
What?
High
That's all.
grade, 103.
So
Yes.
only 2 days fever, and for last 3 days there is no fever at all.
Only GI symptoms, no fever.
So now she has come up with only GI symptom, only 2 days fever, and now he has come for a GI symptom and he's received some steroid or something.
Yeah, dexamethasone, yes.
Yeah, that's also on the background of that. Whatever underlying, there are two possibilities: whether he had some infection which is now stopped and he's coming with a sequelae following that, but not to forget the treatment history here, where he has received steroids, which is going to suppress any kind of a inflammatory, infective, whatever process or mask it. Now, clinically, this child is sick, right? When he came to you, or is stable otherwise?
No, he's stable. He's having, like I said, he's having almost all the markers are stable. His airway,
Perfect.
breathing, circulation, everything is okay.
So if it is steroid suppression of an inflammation or inflammation underlying, infection underlying, I would have seen the child to be sick with only fever disappeared. Here your child is also stable at this point of time. So I have reason to believe that yes, this could be MISC only, which your steroid has temporarily kind of taken care of it, and rest of the parameters is inflammation which is taken care of. Had it been infection on the background of steroid, though the masking of the fever, but rest of the things would have progressed and child have become more sick at this point of time. So my take on this child, high grade fever day 1, day 2 goes with MISC, mucocutaneous presentation goes with MISC, abdominal symptom goes with MISC, and then you will be showing me the parameters subsequently. I would love to see the first base parameter which we have seen at Ludhiana,
Yes,
and the one which you are seeing today. But looking at the progress, and you tell me the child is clinically stable, airway, breathing, circulation, hemodynamic, everything is okay. Child is otherwise comfortable and is responding to steroids. I will take it at this point of time on the present epidemiology as a MISC, though there is no contact history. But also you have to take in consideration a probable tropical disease. But as of today, looking at the response and the progress, I will take it as MISC, which is a mild inflammatory variety.
So I 200% agree with Mahesh on this. And we also kept the same when the child came as a MISC as a first possibility and rule out other infections. And similar to the previous case, we wanted to work up on the same lines. So tropical infections are very common in our part of the world, and they are leading cause of morbidity and mortality. And the common infections which we see as per the last published data in the BMC infectious disease, malaria, dengue, salmonella, bacteremia, leptospira, chikungunya is very common. But I would keep scrub also very high in India or in North India at least. But I think it's now pan-India which we see. But we are also having features of MISC which are overlapping, and that also now come up. So we have to keep a broad-based differential diagnosis in this. So how can we differentiate between the two? Usually tropical infections, though they are again, like I said, they are very subtle differentiating feature, not hard and fast. MISC has a past history of contact or patient himself is positive. Fever of acute onset, the other ones may have a prolonged fever. You have an early organ dysfunction, and multi-system involvement is common in MISC. Rash can be of any type. Splenomegaly usually is not there in MISC. And you have more of mucocutaneous signs and symptoms, and they respond very fast to anti-inflammatory therapy. Like Mahesh said, they improve very rapidly with treatment, and even the coronary involvements also improve very fast. So severity of increase in the level of inflammatory markers, which we see very commonly we're doing nowadays in almost all the patients of this kind of presentation, they may not help to differentiate between tropical infection and MISC because they might be raised in both. So MISC definition, if we go as per the definition in this case, you have a child obviously fits into this fever for more than 3 days, although in this case it was only for 2 days. So does not classically fit to that, but now like he has received steroid, so fever may have been suppressed because of dexamethasone. You have subsequently on investigation, we found coagulopathy, we have GI symptoms. You had high ESR, CRP or procal in this, but then there were other things which are negative. So can we really put into MISC? But again, like everything may not fall into that definition. So on investigation, Dr. Basavaraj, we found this on day 1. We had count of 5,800, predominantly polymorphic, though lymphocytes were low. You have now thrombocytopenia. You have raised liver enzyme. You also have raised bilirubin. and you have decreased albumin also in this case. And the trend of platelets gradually improved, and the counts also gradually improved. The OTPT means at least the AST improved, though the PT remained almost the same. So what do you comment on this? Or maybe we can go to the other investigation. Yeah, let us go to that later maybe. So can you comment on this?
See, when you look at this investigation, presence of a lymphopenia, once again, I'll strengthen my thoughts of a MISC. That is one. Two, platelet count. Usually you don't expect an increase in the platelet count. So this one, that is the things which a little bit. Bilirubin is not the thing what we have so far we have observed in the MISC. Bilirubin is not the thing which is affected. SGOT, SGPT things is the thing. So it is giving a mixed signal. Yes, MISC is a possibility, but we need to keep something into the mind. Like entry.
Okay. Yes. Great. So I think with this, we may not have a very much of the information. We move forward. So CRP was very high. Procal was also slightly raised, not significant. IL-6 was high, and D dimers were also high. And we did COVID antibodies, which are positive in this case. But interesting thing was that the admission blood culture, which came on day 2, grew Salmonella typhi, which was sensitive. And typhi.IgM was also positive, but other workup was negative. I think similar question has been raised by Thangavelu sir also, that now we have a COVID antibody positive, suspected MISC, but also grows Salmonella typhi in the blood. How will we manage this case? So Dr. Mahesh, any comments on this? His echocardiography was normal.
I was just wondering, Arun, had you got the blood culture negative, what would have been your take on this?
Oh,
you got a blood culture positive, which has guided you rightly, but confirmed enteric also, positivity of blood culture is just about 50%. So it's a flip of.
Yes.
And had you got it negative, what you would have done this child? You perhaps would have treated him.
And we would have continued with MISC.
And you would have given steroids, and your ceftriaxone maybe continued, and otherwise also the child would have recovered, right?
Yes.
Blood culture positive, which is discussing this case in a direct direction, but in a field where even cultures are not available, or where it is available, where it may come positive genuinely or negative genuinely, where the treatment is going to be probably the COVID antibody positive with the CRP 178, which I don't see in enteric very often. That CRP 178 match with my enteric. My procal negative can be anything. My IL-6 I don't do in my enterics. In fact, I'll tell you, in my first 25 years of practice, I did my D dimers not more than total 25 times. And in last 1 year, I must have done at least 500 times. So that's a change COVID has made. So similarly, many of these investigations are guided by the COVID epidemiology today. So similarly, CRP with the initial rash picture, with the response to steroids, with all those things, yes, I would send a blood culture definitely. If it comes positive, I'm happy. If it doesn't come still, with the whole picture being dicey, in a clinical scenario in the periphery, the poor pediatrician is going to run him with a load of steroid and a ceftriaxone, and the child is going to get better. So I'm slightly diversifying, but I'm trying to look at it from the practical aspect.
Yes.
Yes, it looks COVID antibody positive. He is a MISC with enteric combination. I will take this case as a MISC with the enteric combination. It's a co-infection which you happen to get in this child. That's my take in this case.
Yeah, 2 comments. One,
yes, please.
We need to interpret your lab investigation in relation to the clinical context. That is one thing. You don't interpret just lab investigation and make a decision. Look at the clinical condition and interpret and take a call. Second thing, co-infection is the thing which is emerging problem, especially monsoon is setting in. So we need to not always, because if you do a COVID antibody, majority of the patients will get a COVID antibody positive because our infections almost 40 to 50%, even though seroprevalence yet to come. So this is the thing. So COVID antibody doesn't mean that it is a MISC and all. We need to look at the clinical condition, then we should take a call regarding whether it is a MISC or not MISC. Over to Arun.
I agree with this. Dr. Hari, do you see these kind of conditions like co-infections with the dengue or enteric or anything like this?
No, thankfully not. I worry quite a lot about the confusion caused because of multiple prevalence.
It's a common scenario in India.
Just one quick comment. I'm looking at this case 2 years later, suppose. After 2 years of a case, your majority population will be COVID immunized and majority population has gone through COVID, and then almost every patient will be showing antibody on the background. And then the problem is going to be more difficult to pick up those MISC if you are relying on the antibody as a parameter to diagnose it. So it's okay because 20% population is infected and immunized.
I know. So this is a difficult one. We have seen now COVID and MISC with the dengue. We have seen this is an enteric. This is currently admitted with us. And we have even seen COVID with the scrub also with us at present. So that's the various manifestations which we had seen. So we can take few of those questions in the chat box.
For the attention of the moderator and the panelist. So we have only 5 minutes left.
Yeah, we just talked. We are now just finishing just a couple of questions, madam. So any other questions in the chat box? I think Thangavelu sir's questions we have already taken up. Dr. Hari has replied. Then Dr. Ramchandran is asking, have you seen severe MISC presentation without history of fever? Any of the panelists?
Yes, I have seen in one patient up in a MISC. This presented to myself and Raghunath was there. This patient presented to us with a left ventricular dysfunction. Then we investigated it. We were clueless. It was in the night. So all the inflammatory markers was in the sky eye. This is in the first wave. And COVID antibody was positive, LV dysfunction. So finally, we treated like a MISC with neurological complications too. Not only cardiac as well as a neurological complication with raised inflammatory marker. With the diagnosis of other things has been ruled out, blood culture and other cultures was normal, but this patient was presented without a fever. Only one case I have seen.
Hari has said they had almost 100% patients had fever, so none in his answers. So
MISC, yes, all had fever, but I had one comment related to MISC-N, the neonatal presentation. That's something which is now coming in a big way. And I have seen about 3 or 4 cases which presented out of a blue moon. So you see any unexpected deterioration in any neonate in your nursery, keep this as a differential diagnosis. It may be a baby who is asphyxiated for any known reason. So we already had a baby delivered at 3 o'clock in the gynec nursing home, and he had a fetal-maternal transfusion like issue, but severe myocardial dysfunction. The ejection fraction was just about 10 or 12. We lost that baby after 3 hours. And then the mother turned out to be positive and COVID antibodies turned to be positive. So you get any deterioration within first 2 weeks of birth. Think this as a possibility because this is becoming endemic, epidemic and pandemic and everything. So now in next 2 years, you have unexpected deterioration of a newborn. Think of this as a differential diagnosis.
Yeah. So any last minute pearls from Hari?
MISC is a diagnosis of exclusion. There is no confirmatory test. There is no way of reliably ruling it out also. Unfortunately, that is going to be a conundrum for some time until something is invented.
Yeah, that's, I think, a word of wisdom. So you have to rule out many other things before you label that as MISC. So I thank all my panelists. Hopefully they enjoyed and everybody enjoyed and we had a wonderful discussion. Hopefully we were able to answer a few of the questions, but I think instead of answering, we raised many more questions than what we answered. And only time will tell and we will be more wiser. So thank you, everybody. And we hand it over to the chairperson, please.
Our heartfelt thanks to the most learned moderator and panelists, Dr. Arun Bansal, Dr. G.V. Basavaraja, Dr. Hari Krishnan, and Dr. Mahesh Mohite for that enriching and illuminating session on MISC. This sure has thrown light on many areas in the management of MISC. Thank you so much, sirs.
Thank you.
Thank you. Thank you.
With that, we move ahead with the next session.